Coming to the third generation cephalosporins, we have cefixime, cefotaxime, and cefotaxime, ceftriaxone, cefdinir, ceftibuten. And three of the six third generation drugs are IV and three are oral in the third generation cephalosporins. Cefixime oral, it is treated for gonorrhea and it's used for UTI as well. And cefotaxime, it can penetrate the CSF and elimination is done by hepatic and renal. Ceftazidime, it is active against Pseudomonas aeruginosa, and ceftriaxone, it is a drug of choice for gonorrhea. It is a very important drug, ceftriaxone IV. It is a drug of choice to treat gonorrhea and it has longest half-life, that is 8 hours, and it is excreted, bile excretion is done, and it can be used in case of renal diseases, and it also has a good bone penetration. The rest of the drugs like cefdinir, ceftibuten, these are orally given along with cefixime. Two drugs, cefoperazone, cefodoxime, these are no longer used. Right, and these drugs can cause like bleeding and thrombonemia. So these drugs have to be given with caution. Coming to fourth generation, one drug is there, cefepime IV. It is the activity is same as third gen, but it has more resistance to beta lactamase. So if suspected that beta there is the infection, the bacteria causing the infection is resistant to penicillin, cefepime is given IV. And in fifth generation cephalosporins, ceftaroline and ceftobiprole, it is active against Pseudomonas and MRSA effective, which means that it is methicillin resistant Staphylococcus aureus. Right, so these two drugs, that is fifth generation drugs, cephalosporins, these are given to treat against Pseudomonas and methicillin resistant Staphylococcus aureus. One important point to remember is all cephalosporins, they have no activity against Listeria, atypical mycoplasma, chlamydia, and enterococci. And most of the drugs, they do not have any activity against MRSA except these two fifth generation cephalosporins. All these drugs, they have no activity against methicillin resistant Staphylococcus aureus infections except fifth generation. So that is one important point we need to remember. Next drug is vancomycin. It is not affected by beta lactamase, so it is a good drug, an alternate for penicillin. That is, it is used in the treatment of penicillin resistant strains and bactericidal against gram-positive. Side effects include Redman syndrome, nephrotoxicity, and ototoxicity. It is used for treating methicillin resistant Staphylococcus aureus. IV drug is given. So vancomycin can also be given for methicillin resistant Staphylococcus aureus along with the fifth generation cephalosporins. It is an alternate treatment for infection, superinfection, that is superbug, by Clostridium difficile in patients with P. colitis. And in this case, oral vancomycin is given. Next, Mm, Protein synthesis inhibitors. Next classification of antibacterials is protein synthesis inhibitors. In this, we can divide divide the drugs into two categories. That is, 50S antibacterial agents and 30S antibacterial agents. Under 50S antibacterial agents, we have macrolides and lincosamides. Macrolides have erythromycin, azithromycin, clarithromycin, and lincosamides have clindamycin, lincomycin. And 30S antibacterial agents are aminoglycosides and tetracyclines. Aminoglycosides have gentamicin, streptomycin, kanamycin, and tetracyclines have doxycycline and minocycline as important drugs, but we also consider demiclocyclines. Tetracyclines, these are the drugs, right? And tetracyclines, erythromycin, trimethoprim, clindamycin, chloramphenicol, these are all bacteriostatic. That means they just immobilize the bacteria, they do not kill the bacteria. So that is an important point that we have to remember, is tetracycline, erythromycin, trimethoprim, clindamycin, chloramphenicol. These drugs are just bacteriostatic. Now coming to macrolides, few important points in general about macrolides are PO is orally given, right? So PO means orally given. So azithromycin, erythromycin, clarithromycin, azithromycin, and telethromycin, these are the drugs commonly used. Azithromycin has a long half-life, that is 68 hours, and it is given in single daily doses. On the other hand, erythromycin has a very short half-life, that is 1.2 to 2.6 hours, and it is used for mycoplasma infection. Erythromycin and clarithromycin, these are the inhibitors of CYP3A4. Therefore, it potentiates the toxicities of other drugs, that is digoxin, corticosteroids, lovastatin, sildenafil, tadalafil, and vardenafil, and carbamazepine. So that is one very important point that we have to remember. Erythromycin and clarithromycin, they inhibit CYP3A4. Thereby, the toxicities of these drugs may occur. Clarithromycin increases warfarin, digoxin, and theophylline levels that we have just now discussed. And azithromycin is very effective against gram-negative and H influenza than erythromycin. Clarithromycin is effective for H. pylori and is given in combination with protein pump inhibitors as triple therapy. So erythromycin, azithromycin, and clarithromycin prolongs QT prolongation. Therefore, it has to be given with caution, especially when combining with other drugs, which also causes QT prolongation. Under macrolides, we have to remember two main important points. That is, erythromycin and clarithromycin, they inhibit CYP3A4. Therefore, if other drugs such as digoxin, corticosteroids, lovastatin, sildenafil, tadalafil, and vardenafil, and carbamazepine, if they are given along with these drugs, there is a chance of toxicity. So we have to be very careful. And also, erythromycin and azithromycin causes QT prolongation. So any other drugs which also cause QT prolongation needs to be cautiously given or avoided preferably.